So hello, I think we should start the session because I think we've got all our people here. Great to see everybody here. Welcome to you all, and thank you very much for joining what I think is going to be a really good session. My name is Cathy Smith. I'm going to be the moderator, the chair of the session, if you like. If you think back over the years, there have possibly not been that many bright lights on the horizon when we're talking about Alzheimer's. And we are really potentially at a different point now where we are seeing a new wave of disease-modifying therapies on the horizon anyway. People are talking about the possibilities of breakthroughs. But the question we want to ask today is, are health systems around Europe actually ready to deal with these new developments? Ready, for instance, to detect and diagnose early, because that could be a crucial part of making the most of the new therapies, or to monitor the effectiveness of the therapies, all these sort of things which need to be thought about and need to be planned. And we're talking about health systems that are obviously regional, national, and also at European level. So at every level, seeing about what more can be done. We obviously want you to join in, and I think if you've already been taking part in some of the sessions, you know the drill, you know that you can ask questions. We're just on Zoom, so you can ask through the Zoom chat function. And I want to introduce our panel to you. First of all, we have Charles Scerri, who is the Vice Chairperson of Alzheimer Europe. He's the Professor of Dementia Studies at the University of Malta and also authored the National Dementia Strategy for Malta. So hello to you, Charles.
Hi.
We were just saying before that Charles has got the badges behind him from other meetings that he's gone to, over the years. And sadly, I don't think there will be a badge this time, Charles. Sorry.
Yeah,
Philip Scheltens is the Professor of Cognitive Neurology and Director of the Alzheimer Center at the VU University Medical Center in Amsterdam. People will working in the field will know the Scheltens scale for assessing possible Alzheimer's patients. And I think you also were an architect of the Dutch dementia plan. I tried to say your name in a Dutch way, Philip. Don't think I managed it. Sarah Garner, I can say your name, Acting Program Manager, Health Products and Pharmaceuticals at the WHO, the Regional Office for Europe. And Sarah, I know that your work involves looking at system readiness for access to medicine, so it's absolutely perfect for what we need today. Couldn't be more relevant. And finally, Dr. Antonella Santuccione Chadha, who is Head of Stakeholder Engagement for Alzheimer's for Biogen. And Antonella, she's a medical doctor and a neuroscientist. So welcome to you. Great to see you. And I'm going to ask you actually to start off for us, please, Antonella, because I know that you're going to take 5 minutes now to give us an overview of the recent scientific developments, the way that they are at the moment, and also details of a new FPA paper, which really is right at the heart of what we're talking about today, which is looking at the readiness of health systems. So let me turn it over to you.
That's right. And thank you very much for this kind introduction and for the opportunity and the privilege of introducing you to the work that has been done by FPA as a collective exercise from those who are trying to bring a therapeutic solution for Alzheimer's disease. This work, it's referring to a white paper issued in October this year, and it is concentrated to analyze what it is the health care system type of readiness within the European territory. Well, we all know what it's Alzheimer's disease, and we all know that it is a progressive neurodegenerative condition starting decades before the symptoms becomes manifested. And those symptoms start to be obvious with very mild type of symptomatic at the beginning, and then they develop in full type of dementia later on. Now, we know that it's also the most common type of dementia, representing almost 60–70% of the dementia cases in total. And we also know that in Europe, actually, we have that around 10 million people are affected by this condition. And this number, it is expected to rise simply because the population is meant to age. So we're going to have an assumption that by 2030, we might have 14 million of people living with this condition and suffering from this condition. Now, we have a guest from the WHO on this panel discussion, and this is highly valuable, especially considering that the WHO has recognized as dementia one of the priority in their agenda, and also listed dementia and Alzheimer's disease as one of the 5th leading cause of death. Now, Alzheimer's disease currently, it is a condition which is treated only with symptomatic type of treatment, and very often even off-label. What we hope is that soon disease-modifying therapies, which are targeting earlier stages of the disease, might be available for the patients in need. And this is particularly important because we said that this condition develops already years before the symptoms becomes manifested. So we need to recognize timely the pathological process. We need timely to diagnose and bring a therapeutic solution when the damage, it is not yet so advanced that nothing or just a little bit could be done. Now, the major point of the work that the FPA has been generating, it is that the healthcare system seems to be not prepared to do exactly this. The healthcare system within Europe lack the capacity to detect early, to diagnose timely, and to treat Alzheimer's disease in an effective way. And this might represent a hurdle for potential disease-modifying treatments that might access the market in the future. Now, we know that Alzheimer's disease represents one of the most significant public health crises, and numbers are going to be as such that might affect also us in the near future. Us, I mean, those people participating in this panel. And that's why the time it is to act now, because we might all become this patient in need of a therapeutic solution, of a timely diagnosis to manage at best the disease. And I want to conclude just with one last statement. The WHO last year also issued relevant information about the timely diagnosis based on the fact that we have the capacity of preventing the onset or delay the onset of dementia by working on specific risk factors. So I think that we really have to act such as that this is possible and bring an holistic type of approach to the disease management. Thank you.
Thank you very much indeed.
I have just one last point. This is the slide which summarizes actually the call to action actually, and that it's reflected in the paper, and we might want to comment all together later on. So the 5 points which have been recognized, it is that we need to make Alzheimer's disease and dementia as a priority in the European policies with a dedicated type of funding. We have that we need to develop and implement ambitious European plan to defeat this condition, ensure that the EU4Health program foster member states collaboration in the Alzheimer's disease ecosystem related to the healthcare system readiness and also the social care system, which needs to be implemented, put in place. We need to harmonize and disseminate independent evidence-based, of course, detection and care guidelines. This is crucial to have guidelines in place which will guide, of course, evidence-based for the benefit of the healthcare provider, but mainly for the benefit of the patients and the caregivers across Europe. And finally, we need to support an adoption and above all an implementation of Alzheimer's disease national plans, which assess and set clear objectives towards what we define national healthcare system readiness. And in the hope, as we said, that disease-modifying treatment will access in the future the therapeutic market.
Thank you very much indeed, Antonella. So that gives us a sense of what you would like to see happen and what FPA would like to see happen. Let me just turn to our other speakers and ask the big question, whether you actually do think that we are at a turning point in the treatment of Alzheimer's. Do you agree with that? Maybe I could ask you first, Charles Scerri.
Yeah, if you want a direct answer, in a certain way, yes, we are. And the best example to this is that following a number of years of disappointment, by March of next year, the Food and Drug Administration will decide or should decide on the clinical use of a new drug to treat Alzheimer's disease. But if this is approved, it has been long coming, I have to say, after so many years of disappointing news. However, during all these years of trying, I have to say, we also learned a lot on other aspects as well, in particular, early intervention, long before the symptoms appear, which in some way is leading to the development of some new therapies. Let's mention the biomarkers, even the blood-based biomarkers that are being developed at the moment that help in the identification of the disease very early on. As mentioned, the pathological changes start early on, much before the first symptoms appear. We also made significant progress on the preventive side as well, by studying risk and protective factors in Alzheimer's disease and other diseases leading to dementia. I have to say also that people are more conscious of the treatment options that are available to them nowadays. And I personally keep being asked questions about what stage the research is in. Why are we taking so long, for example? What drugs are in the pipeline, and so forth. It looks like people are doing their own research nowadays, and this is all good, right? I have never been asked such questions 5 years ago, for example.
Well, let me bring Philip Scheltens in and get your view on that. Are we at a turning point? You need to mute your microphone, unmute your microphone. Philip can't unmute. I'm going to get, while you work on your microphone, Philip, then let me ask Sarah Garner. So how much on the WHO radar is the whole business of Alzheimer's? Do you have data? Philip Scott is the microphone unmuted now, but let me stay with you, Sarah. How much on the WHO radar is Alzheimer's? Do you have data? How much are you working on this as an organization?
It's very much on the radar, Cathy. We had a resolution in 2017 with a global action plan for the public health response to dementia, which laid out quite a ambitious set of activities for both member states and the Director General, with a list of priorities, sort of 7 priority areas with toolkits and resources for each of those areas. So it's very much there. And we also have at the European level, we have a mental health flagship for our new European programme of work.
But is there a sense that within your organization that things are changing, that you have got to also up your game to match the fact that there is more actually happening out there in terms of scientific progress?
I think the game is up already. So there's been a raft of activities over the past few years, again, as a response to that global action plan. And if we want, I can go through some of the details of the activity.
Well, let me just first of all ask Philip Scheltens to answer the question as to whether you think we're at a turning point.
Yeah, thank you, Cathy. Yes, I think so. I largely agree with Charles, in fact. So I think it's, while waiting for the FDA's approval, already having a drug at the FDA is already significant progress. We hadn't had that for a long time. If it is approved, it will make a huge change, because for the first time there will be a drug that is registered for Alzheimer's disease, for disease modification, which by no means will be the complete answer. By no means it will be for everybody, but it will be a change for the field. For many people that haven't believed that actually it could work, it will work. And in the meantime, as Charles said, because we had so many failures, we could actually work on the basis of what is needed in the field is proper diagnosis. affordable diagnosis, scalable diagnosis. We started with MRI, with PET, CSF, and now with the blood-based biomarkers, really for sort of coming very quickly to everybody that is in need of it. It opens the field for better clinical trials, wider populations to be engaged in trials, and having better therapies after aducanumab.
But a lot of big pharma have actually withdrawn from the field, haven't they? So how is that not been a setback?
Yeah, a lot. I wouldn't say a lot. Some of them, but I know they keep the back door open. And what they're actually doing is that indeed their phase 3 programs failed, so they have to step back and they are waiting and they are sort of moving into other fields. But in the back door, they have it open and they look very, very diligently to what is happening in the world. And I have different roles, and for one of the other roles I have is to look at investments in biotech companies. And I must say there is an enormous amount of new biotech coming from all corners of the world, targeting different targets in Alzheimer's disease and also other dementias that are worthwhile of spending money in. And ultimately, then big pharma sort of has still an appetite for that sort of biotech as soon as they have credible phase 2 results.
Okay, well, so then let's talk about the crux of what we wanted to talk about is really, are healthcare systems ready for any of these breakthroughs that we're talking about? Where are the gaps? I mean, what you Antonella, you've sort of hinted at some of the things. Just give us a bit more sense of where you think the biggest gap is in the healthcare systems if your drug or other drugs are approved.
Well, there are several I would say, issues that one should try to tackle as soon as possible. Being myself a medical doctor, I would like to start with what it is more familiar to me. And I want to bring the example of what it used to be dementia on my medical books 20 years ago. It was about 5 pages or maybe 4, and we knew really little about this type of conditions. Now the knowledge has expanded. As we still miss specialists which can really diagnose and recognize the disease in a proper way, such as that we do not overload the already existing healthcare professionals with something that can be a bit far away from their daily type of work. So I think this is the first thing to do for sure. And then we need certainly to prepare the infrastructures which are needed to basically recognize the disease, diagnose the disease in a timely fashion, and also be able to bring medical solutions to the patients whenever it is there. And to do this, we need to reinforce, we need to put an asset to make this whole happen.
When you talk about the infrastructure, you're talking what, about PET scans, about lumbar punctures? What are you talking about?
I think we have several diagnostic options available. If we have to look and analyze the situation for what it is today, we have to say that certainly amyloid PET could be a possibility. Nevertheless, the scalability of this solution can be tedious because it is not available everywhere, might be not sustainable by the healthcare system everywhere. So we have other solutions, like for instance, the cerebral spinal fluid biomarkers, the lumbar puncture, which still has to become nevertheless a clinical diagnostic routine on a large scale, because we know that it is available, even this solution, in certain type of specialized centers. And of course, then the very future to be, which is the blood-based biomarker. But nevertheless, those biomarkers, based on the status quo and the current knowledge, will serve as a triage, which means will serve to give a flavor of what the patients might experiencing. We still need a confirmatory amyloid type of diagnostic if the drugs that will access the market is going to be an amyloid type of drug, to then prescribe it to the patients. So still a triage before becoming a confirmatory test when we speak about blood-based biomarker.
Okay, Philip Scheltens, so do you think that early diagnosis is the most important part of the missing part of the jigsaw, if you like, to be able to make the most of these new drugs coming onto the market?
Yeah, for sure, definitely. I think any of the drugs that are developed now and in the future will be targeted to people with the earliest signs of the disease. So we have to, we cannot rely anymore on the dementia diagnosis, because dementia as a stage is far too late to intervene. So we have to pick up people with subtle cognitive complaints and a little bit of a subjective cognitive impairment or objective cognitive impairment. And then with the biomarkers, you show whether there's underlying Alzheimer's disease or not. And that's actually the crucial point where therapy should be started. So yes, there will be huge demand on facilities that can provide a better and earlier diagnosis.
So, I mean, this is hard because we're talking often about quite costly infrastructure here. So how do you create a situation where the investment will come?
Yeah. So that's indeed tricky, and I think that will be sort of in any country in Europe, it will be handled differently. For sure, there's not enough PET capacity, and PET is far too expensive to do it on all people. So that's why I think we should speed up the biomarker development, because biomarkers in blood, for instance, will not give you the ultimate diagnosis, but they can be perfectly used for pre-screening. So instead of running everybody through the PET scan, what you can do first is a pre-screen with an amyloid blood test or a p-tau blood test, and then say, okay, if you're positive, then you get an amyloid PET scan. So you reduce the amount of people that is actually burdening that system. In addition, CSF was mentioned, and this is particularly in Europe. It's very, very different how clinics and people react on it. We in the Netherlands, we do it almost routinely, in the northern countries as well. But in the southern countries, it's less available. So each country has to make up his own mind how he or she will deal with this problem.
So what's the situation, Charles, Scerri, in Malta and in countries that you're familiar with, in terms of whether dementia plans, for instance, have helped to bring any more funding, or where do you see the gaps that need to be filled in healthcare systems if we are really going to tackle Alzheimer's in a way that people would like it to be dealt with?
Yeah. I think we have to realize that the healthcare systems in Europe is not one fit all, and its management is a prerogative of each particular country. Okay, the European Union can give directions, but the actual control of each healthcare system depends on that particular country. So every country has its own system, as Philip mentioned, with various access to support, I have to say, and treatment, and also reimbursement strategy. Yeah? Different countries have different strategies for reimbursement. Detecting and diagnosing dementia early on is an important step, as everybody else mentioned. But in order to do that, we need to have the structures that facilitate early diagnosis. Let me give you an example. What happened in the first dementia strategy that we had for Europe, and it was published by the country France, right? France heavily invested on increasing the number of memory clinics back in 2008, 12 years ago, knowing that most individuals in France will go to a memory clinic to have a diagnosis of dementia. So they knew what their needs were, and therefore they invested there. In Finland, for example, it's the same. But in other countries, diagnosis does not happen in memory clinics, but it happens in, for example, in private clinics, like what happens in Italy. And therefore, then the question that arises there is, are there enough people who are trained in diagnosing dementia in private clinics? And this is an important question. If you asked me about Malta, for example, and I can take Malta as an important example, although I know it's not an exception here. In Malta, people go to their family doctors as their first choice. In small knit communities like ours, family doctors enjoy a lot of respect. It's considered as a friend rather than a healthcare professional and an acquaintance. However, local research that we've done here at the university have shown that they do not have adequate knowledge to do a proper diagnosis, don't even have the time to do it. And unfortunately, only about 4%, it's a very low number of these family doctors actually refer to a specialist service or to a specialist advice. So there's something not working there. I always stress on the same mantra that we need training. It's useless to have services. It's useless to have state-of-the-art technologies if there are no people trained to actually use such technology. And again, if treatments become available, and I really hope, and one day we will get there, effective things that become available. Who's going to administer the drug if there are not enough trained health professionals? And who's going to take care of the costs involved? Because we will know that cost will be, in some cases, very substantial. So these are all very important questions, in my opinion.
Let me bring, sorry, did you want to come in, Philip? And then
no, I agree completely. I mean, having the infrastructure is one, but having people in the infrastructure with knowledge for dementia is an increasingly important problem. And I think, I mean, it used to be very fashionable to work in oncology and to work with all the treatments that are there. And now it should be more fashionable to work in the dementia space, because it's a very challenging and very interesting space to work in. But we have to educate all these people. And also, it also goes to radiologists, nuclear medicine physicians, clinical chemistry labs. They have to really sort of engage in this field that is rapidly changing.
So, Sarah, from a policy level, what can happen? What sort of guidance can come from WHO or to maybe put pressure on countries to develop their own dementia plans? I mean, how can you play a role in this?
So the primary role, WHO acts as the coordinating authority, UN agency for health, and we have a number of mechanisms by which we can act and which has been agreed with by member states. One of them is the resolutions, global action plans, the norms and standards that set out the agenda. What does best practice look like? So in the dementia arena, we've sort of said we've got sort of 7 different categories. So it's looking at the recommendation around the development of national dementia action plans. So we want every country to have a national action plan, and the target for 2025 is 75%. And then awareness raising campaigns, looking at risk reduction, treatment, diagnosis and care, and then importantly support for carers, and then information systems that are required both for exchange of information and support, and then obviously the research and innovation agenda. So there's a set of 7 different categories of activity with support tools and resources in each one of those, and the process is that periodically the WHO Secretariat is asked to go back to the World Health Assembly, to the regional committees, to actually update on progress and actually look at what is being implemented by different member states.
Okay, so Antonella, then, if the WHO is coming out with recommendations and a 7-point plan, is it enough? Who needs to take the lead on this?
Well, first of all, I'd like to make a comment on those recommendations, and I liked a lot the one about innovation. I think that where the future is going to bring us is also a transformation towards digitalization of how we manage the disease, of how we recognize the disease. And I am pretty sure that those startups that Professor Scheltens mentioned earlier, there might be also a few of them heavily engaged in understanding before any type of symptoms becomes manifesting on how to recognize this condition, with digital tools that can be just available on our smartphones. And I think this is where it's certainly an area to invest. And I think it's going to transform the way we do manage the patients, the way we do recognize the patients, and eventually even the future of clinical trials development might look very different from what it is today. So I think the future is bright. We are in a very, in a phase of transformation indeed. And the failures we had in the past have been generating an enormous amount of learnings that it is now leveraging a completely different type of discussion around dementia, Alzheimer's disease, but I would say around the whole neurology sphere, around the whole psychiatry, because what has to be done for dementia, we should not forget, has to be done for any other type of disease in the field of neurology and psychiatry.
But you must have been very frustrated in the years gone by when so many other disease areas are given so much more importance by policymakers, and it's seen Alzheimer's has been put on the back burner, if you like, has been tended to be forgotten about. But do you really think that is changing now?
It is changing, and it has to change because, you know, I always bring the example of what happened with HIV. In HIV, we had a situation where we didn't have a treatment. We had a highly stigmatized condition at the beginning. People were very reluctant to be diagnosed, and slowly, nevertheless, the engagement of the stakeholders in the field, starting from the movement of singers we had in the United States, for example, and then embracing everybody else, generated the critical mass of patients that was awaiting for a solution. And over a time frame of less than 20 years, we finally have a treatment. And we should do the same for Alzheimer. We should, each of us, as I said earlier, it's a potential candidate to get this disease towards the end of our life. And this is where we're less resilient, where we are more fragile. So we need to act early enough, advocate, become the ambassador of those patients who might have not a stronger voice, as a cancer patient who can fight really hard for having a medical condition being released for his cancer. We know that in psychiatry and neurology, patients, they don't have the drive to do that much. So we have to do it instead. And I think, as we said, the time to act is now.
So if the time to act is now, Philip Scheltens, what do you do? How do you act? Who's got to act? That's the point. Who is talking to whom? Where is the funding coming from? Is it better? Is it to be done at a regional, national, or European level? How do we find the solutions?
There's a lot of questions in one, I must say.
But you get the basis of it is there. Just what next?
So the time to act now. So interestingly, I just gave a talk in a few sessions earlier also about prevention, which has the same sort of urgency. The time to act is now, and we have to educate people that brain health is very, very important, and you can actually delay the onset of dementia, for instance, perhaps with a couple of years if you take better care of your health globally. So I think that's already a message. And one of the important things I always stress, and I hear this also, and I think that's one of the reasons that we haven't caught up yet with HIV or cardiovascular disease or oncology, is that there is still a lot of people, and also perhaps governments, that think dementia is a normal part of aging. So just why would you bother? And so for us, the message, and that's why bringing people with younger onset dementia is extremely important, to show the world that this is a disease that you can detect, that you can actually diagnose, and that you can actually treat. And that's why it's a bit of a catch-22. As long as you have no treatment, people will not get excited about it. What can you do about it? So that already, for having one drug, although we all agree that this will have a lot of things around it that we probably have to sort of be very worried about, but still having a drug on the market will change that attitude, because then people will get motivated to say, well, okay, this is a disease. We have to diagnose this. We can track actually the progression over time. We can manage some of the pathological basis of it. So that will make a start. But first of all, get rid of the idea that dementia is just a normal part of aging. Forget it.
Charles Scerri, do you agree with that, that we've sort of broken this catch-22 that Philip talks about, this sort of chicken and egg, if you like, that people weren't prepared to invest because they thought, well, what is the point? We're not getting anywhere.
Yeah. To me, it really does not make sense. To me personally, and to many people out there, it does not really make sense that such an important condition that costs so much money on national and global scale is not given enough priority in comparison to other medical conditions, such as cancer. Many mentioned cancer, but I also mentioned heart disease, for example. And as Philip said, the reasons may be various. But what I have to say is that in many countries, dementia is a latecomer. Serious discussion on it has only started in these last maybe 10, 20 years, compared to about 60, 70 years with respect to cancer. So there's not a lot of time in the public discourse to discuss in depth the health, the social, and the economic consequences of dementia, even though many healthcare professionals have been sounding the alarm for quite some time. Where still, in some countries, the discussion has not even started. And as Philip said, unfortunately, stigma and ageism remains prevalent in many countries, and we have seen this also lately with COVID, where I saw a lot of ageism being thrown in the equation there. So there's the wrong perception that dementia is basically a condition of old age, and this does not really help. And again, having more people with talking and having dementia at a younger age definitely helps in changing this perception. And another thing is that in most cases, and this was mentioned by one of the other speakers as well, most cases policymakers and hardcore politicians included respond to the needs of the public. And unfortunately, people with dementia do not have a voice, or their voice is not strong enough to grab the attention it duly deserves. Simple as that. You mentioned Cancer Association. If I take Malta, the strongest NGOs, non-government organizations that we have here locally, are in the cancer area. Why? Because they can fight really strongly about their rights, and rightly so, I have to say. People with dementia cannot do that, and their caregivers cannot do it because they are so overwhelmed by the caring process. So who fights for these people? People who do not have dementia most of the time.
So Sarah, from a policymaker's perspective, who do you have to talk to, and how do you have to kind of get this moving, if you like? I mean, this means talking to policymakers, talking more closely with industry. Does it mean new partnerships have to be formed? How do we kind of create a new ecosystem to deal with this problem in the way that it deserves to be dealt with?
So I think the part of me, so I'm going to focus a little bit on the drug issues. For the other, the advocacy, I think the WHO has set out the responsibilities of member states, and member states have agreed to that. So in terms of advocacy for what should be happening, the tools are there for various non-state actors to do that advocacy process. That's there. In terms of getting this moving, the issue is always financial. And we are talking a massive, ambitious programme in here that borders on healthcare, social care, and public health / prevention. So we need to understand that actually, if we're going to achieve this, it's going to take significant investment, and just come together as a community to discuss how we're going to achieve that, what needs to get done. And certainly from the perspective of like my speciality, I worked at NICE for 17 years before I came to WHO, and I was involved with the appraisals of the cholinesterase inhibitors. I am really hoping that we have learnt from that experience. It took such a long time to go through those processes. Yeah. At entry, these were expensive drugs at the time. We are talking such a large potential market here. I would hate for discussions of value to start restricting it to subgroups of patients, which we see so often. We're going to have to start, if we want patients to receive these drugs, we need to start thinking now about price volume agreements, about Netflix type models where you agree for a service for a population, and that is going to need collaboration, communication, discussion between the public and private sectors. As I said, it's a large, very large market we're potentially talking. So we shouldn't be trying to push the price as high per patient as we can. It needs to be about access and penetration to all patients. So I hope we've learned from the previous experience, let's have those discussions, and also bear in mind there's going to be a lot of uncertainty at the time of launch about the long-term effects. So how, as a community, are we going to work together to put in place either the information systems, the data collection systems, different sorts of studies that are going to need to ensure the safety and follow-up for effectiveness.
So Antonella, if we're talking about the public-private partnerships that are necessary, it would seem to really make a success. How do you see that playing out in the future then?
Well, I think that it is already a reality. An example, it is the type of platform that FPA has kindly provided to those playing a role in finding either a cure or a diagnostic tool. And this is why we came out with the white paper that we are discussing currently. But I think that there are also other examples. I can share, for instance, that Biogen is collaborating in a project which is called PAVE, and there where multiple stakeholders come together and try to analyze again issues related to the healthcare system readiness, on how to address the gap existing in the Alzheimer's disease ecosystem. Because what it is important is that this is a type of exercise that cannot be solved by one party alone, especially when it's about transforming all what we mentioned so far. We need to educate different type of stakeholder to what it is the disease, remove the stigma around it, diagnose timely, prepare infrastructure to prescribe the drug or potential drugs. So basically it is something that none of us can be doing alone. And I think we are going in a direction of collaboration between private sectors, with public sectors, even with academia. There are brilliant collaboration with the academic institutions that are trying to characterize, for instance, the journey of a patient from a real world evidence perspective, etc. So I think we have lots of examples ongoing, and it's going to be more and more.
Somebody says in the question box says, in my opinion, healthcare systems are not ready for the implementation of the new generation of drugs. Is it worthwhile to envisage a guided implementation in the form of a phase 4 trials to overcome this? I don't totally understand the question, but maybe Charles or Philip could respond to that.
I think that's correct. I mean, I think that's also the essence of this discussion, is that the healthcare systems at the moment are not ready at all. And I think, personally, I think for Europe, I think the EMA and also Europe in general is a little bit more cautious in getting this sort of treatments out there, and that may be the case that they will allow the drug to be on the market in a sort of controlled way, which is a phase 4 kind of trial, where you select the centers that are able to do it, and also discuss the type of patients that need to have these medications. I'm very much in favor of that, because as you said, I mean, it was said, I mean, it is huge market in principle, but in fact, if you look at the specific drug that we're now talking about, with having 4 weekly infusions, having MRI, etc., I think the amount of people that really are eligible for this type of intervention is actually smaller. And perhaps it's good not to sort of throw away the baby with the bathwater, is not to give it to any patient, but really think about what kind of patients, and get the healthcare system increasingly used to this type of medication gradually and not in once.
And in terms of the EU level, I mean, you've referred to the Innovative Medicines Initiative, which obviously is a partnership with the EU. What role should the EU be playing, or what role should national governments be playing? Where does the sort of the burden fall, if you like? Who's responsible? Who should be doing what? Charles, Scerri, what do you think?
Yeah, I have to say that Europe always plays an important role in this particular area. If we look back, for example, what happened 12 years ago in the first conference about dementia in the European structures organized by France, in which France presented its first dementia plan in 2008. It was the first country in Europe to actually present a plan. And what happened is that many countries followed suit. And what we saw is that there was an increase in this attention towards having a dementia strategy. So there was an important recognition there. But then again, countries like the Netherlands, countries like Malta and Slovakia put dementia as a top priority during their 6-month presidency stream. What needs to be done or continue to be done from the European point of view? So what I see is that the European Commission needs to continue promoting and supporting international collaboration. International collaboration in this area is extremely important, and also improve coordination of existing European research programs, for example, JP&D, IMI, Horizon 2020. What member states, in my opinion, should do is to continue working together in the exchange and implementation of best practices in dementia care, in diagnostics, and also in prevention strategies, because we have seen in studies show that prevention can have an important can be an important factor in reducing the incidence of dementia. On top of that, we need to continue supporting individuals with dementia to have the best quality of life possible, that they are able to live with dignity and to participate in society in line with their human rights. But last but not least, I have to say that we need together to continue to stimulate and promote the development of a society, and this is very important for me, that supports and accepts people with dementia as worthy members of society.
But I think you mentioned before, Charles, and Antonella, perhaps I can bring you on this, about the whole business of training of people to work in this field. Somebody in the question box says that effectively it's not very sexy to be a gerontologist. You know, being a cardiologist or a neurologist or a surgeon may sound more exciting than a gerontologist. But it's not just specialists you need, it's also that GPs, general practitioners, need to understand more about how to diagnose. I mean, what's your view, Antonella?
Exactly.
Oh, sorry, Charles, if you want to come in first, and
then this is true, because when I ask my students, my medical students, about what they want to do as a specialization, if they ever have to specialize, nobody mentions dementia. Everybody mentions oncology. Everybody mentions cardiovascular disease. So, in part, as an educator myself, I'm failing my students because I'm not throwing enough seeds out there to increase the interest in this particular area. And we need people in this particular area. Maybe cardiology and maybe oncology has more exposure on TV, even TV drama that people see, for example. There's not so much on dementia. And this is very unfortunate, because what happens is that when they graduate, and we are not doing enough during the formative years, we concentrate mostly on postgraduate training, but not for undergraduate training. We are not preparing them enough. And what happens is when they graduate and become doctors, become nurses, occupational therapists, speech language pathologists, for example, they don't have enough educational tools to help these people. Right. And we are concentrating too much again on the medical model, sometimes leaving the social model completely out of the equation, which is something that I really don't agree on.
Philip, what did you want to say?
Well, I'm a little bit more positive. I think being a neurologist is very exciting, just as a note. But
I would have thought so too.
Well, and the field has changed completely, dramatically also for neurology. And it will again, I mean, this is the catch-22 again, that will change. I mean, this sort of therapies, and there will be intrathecal therapies. Mind you, there are other therapies to be developed that really require ultimate skill. So I think dementia for the future is the most exciting field to work in. And we have to, because the amount of patients will be huge. I personally think in the Netherlands, we did really very well. We trained a lot of neurologists that are all opening memory clinics. And in memory clinics, there's always a geriatrician and a neurologist. We have a large network of memory clinics where people really are engaged to make the best of a diagnosis and also follow up, preparing for what is to come. So I think it's a question of also promoting yourself, how important this field is, and to make other people enthusiastic about it.
But Antonella, it's not just specialists, is it? That, I mean, you know, as I said, it's if we're talking about early diagnosis, we need medical practitioners who know a little bit more at an earlier stage.
Absolutely. I think this is extremely important, because what also Professor Scheltens mentioned earlier is that we have to remove the concept that dementia, any type of dementia, will be part of normal aging. We know it's not. We know that we have a brain that has to be kept very well in shape like any other organs, and that we have to take care of our brain health. So we need to remove this construct of dementia and necessarily aging. You know, this equation has to not be an equation anymore. We need to say that dementia is not part of normal aging. General practitioner needs to be empowered and educated to the fact that they can recognize symptoms, early symptoms, and address the patients to the specialist to do something about it. And actually, Professor Scheltens was right. There is certainly a geographical attitude that changes across Europe, where Nordic countries might be more advanced in this type of dialogue. And for whatever type of social construct, the southern country might be far away from that. Yeah. So, and I think this is where we need to educate, yes, the doctor to be, we need to educate the general practitioner which are out there to what it is dementia, to those old marks of the pathology, explain what it is A beta, what it is tau, to explain that the symptoms becomes manifested when already things have happened in the brain. And so if we want to do anything like early intervention, we need to recognize timely. And I think most importantly, the prevention part. I think that we have knowledge that if I'm not wrong, Professor Scheltens, you might want to correct me, there are 12 risk factors that the Lancet Commission has identified that could be modified by lifestyle changes, by keeping control of other factors like hypertension, diabetes risk, etc., to delay the onset of this cognitive decline. And this is where we need an education to a global level. Governments even have to put campaigns in place, because it's going to benefit their how do you say, their cash. You know, they're going to be having an advantage of reducing cost of patient management later on, right? So it's going to be a sustainable exercise. This is why we have to bring precision in diagnosing the patients timely, recognizing the type of patients, intervene, and educate to a preventive measure. This is what really needs to be done in a tailored way.
Yeah, no, I agree completely. I mean, that's 10 or 12 risk factors, but it's actually, we need both. So we cannot rely only on drugs because there will be not enough, and there will be we have many years to come to have a real medication to choose from. But in the meantime, we can do a lot to maintain our brain health and to prevent some of these changes, especially at older age. So if you start now at middle age to do things and change things, so you have to always have both approaches. And also people need to be informed on that, but healthcare providers need to be informed that it really makes sense. So what is good for your heart is also good for your brain. So it's, again, education and frappe toujours on the same subject.
Well, Sarah from WHO, I mean, you know, this all falls into potentially your area of work in terms of prevention, awareness raising, training of health professionals. What are your thoughts on the comments that have just been made?
No, absolutely. I think there's nothing I don't agree with on this, that it is going to take an enormous amount of effort to get the systems where they need to be to deliver on this. And the question is how that activity is coordinated, both at a European level and at a member state level. So just if we look at the drugs, so to actually, and I've looked at the comments coming through on the chat, that if we are going to have something like a conditional license for early access into specialist cares, we're going to have robust data collection methodology. It's going to need coordination between industry, patients, professionals, healthcare systems, HTA and payers. So how are we going to get that coordination happening together, and where do those discussions take place? And I think at the moment we don't have that infrastructure to enable it to happen. I think there's some pilots happening in the UK and the Netherlands around using real world data for assessments of clinical and cost effectiveness. We need to do more, and we need to anticipate. So let's not wait until these things get into the regulatory systems. We've got the experience. Let's think about it in advance and plan prospectively.
Somebody on the chat says, what do you have to say about social prescribing? Is this a reality on the part of clinical practitioners? Philip Scheltens.
Yeah, I'm not sure. I read that comment, but what is meant with social prescribing? Perhaps I'm familiar with the term.
Perhaps it's a care pathway that includes the informal caregiver feedback, community support, basically, to individuals with dementia and also their caregivers.
Yeah, I think that's completely logical, and for me that's common practice, but perhaps something else is meant.
Yeah. So just in our last 5 minutes then, I want to just ask you all then to sort of sum up and tell me what you think is at stake here. How important it is that we get this right at this stage where we are talking about the potential for therapy, new therapies coming on the market. We've got to make sure that the health systems can cope. What would be a real priority action, and from whom, to really make a difference? If if you had a magic wand and you could wave it and something would happen immediately, what's the most important next step to make a difference? I wonder whether, I don't know who wants to start. Yes, Sarah.
I can go first. I'll give it a go.
Yeah.
So just from my perspective, I can talk about the practical next steps that WHO is going to do. We're hosting an initiative called the Oslo Initiative, co with Norway. And this is about developing a new social contract towards access to high-cost novel medicines, where we create a platform for actually those coordinated discussions to happen about the roles of the public and the private sector. And this is exactly what we need to happen, is what are the different roles of responsibilities with respect to access, financing, pricing, and innovation, importantly, because we need sustainability for this process. And I think the long haul we've been on for Alzheimer's is a case in point.
Okay, that's really interesting. So Charles, Scerri, what would you say?
What's at stake? There's a lot at stake. In fact, the quality of life of these individuals, for sure. We know that people with dementia will continue, their number will continue to grow, and doing nothing is not an option. Not even the status quo is an option. So we need to aim high, and we need to go strong in terms of intervention, and we need to do it now, because otherwise we're very close, otherwise we will miss the train. So it's very important that we act as fast as we can. We need to invest more in so many levels, I have to say, starting with research. But research not only in terms of finding a cure, but also in terms of how we can improve the support for these individuals. If you ask these people what they want, if you really ask these people what they want, they will tell you, we want a cure. And hopefully we will get there, but realistically, it will take years. We all know that. So there are people with dementia out there who simply cannot wait. We need to help them now. And another point that I wish to mention is that we need to hear the voices of people with dementia more often. These are the people who are neck deep in this particular situation, and their voice is extremely important. And I have to mention here, coming from Alzheimer Europe myself, I have to mention the important work that the European working group of people with dementia are doing, even collaboration with pharmaceutical industry. And we need to hear these people more and include them in whatever we do in this particular area.
Okay, thank you very much. And Antonella, what's your view?
My view is that those players from the industry side that are also within the FPIA framework are doing all that it's possible in their remit to bring a therapeutic solution to the patient. So we are acting now, and we hope to have something for the patients in the near future to come.
Okay, a note of hope. And Philip Scheltens.
Yeah, so I'm also hopeful, but I think here in this particular topic, Europe should be united, and we should really join forces and do our ultimate best to create a better future for our patients. And indeed, it will sort of require huge investments in research, all types of research. But we need to do it. We cannot rely on, for instance, the United States to do it. We have to do it ourselves. And in that sense, it's really a pity that due to COVID, of course, suddenly money streams are going the other way, and COVID will disappear at some point, but Alzheimer's will not. And we have to really invest hugely. It is no other way. And it will ultimately be cost effective because we will save cost at the end, but we have to invest now as Europe.
And do you think that COVID situation, maybe there are things to learn from that, the speed at which things have actually developed in health systems. Has that shown people what can happen?
Yes, the same. I mean, the HIV example was mentioned. I see the same happening now, the urgency, and people need to collaborate. And suddenly the pharmaceutical industry is in the driving seat again, and people are urging them to develop drugs, and money is no issue. We will pay for it. We'll actually order medication before it's actually approved. So things are really different than before.
Well, I'd like to thank you all very much for a really interesting discussion. For our panelists, thank you so much for joining us. Thank you for everybody for watching. Thank you for your questions. We got to some of them, not to all of them. And do enjoy the rest of the event and have a very good evening. Goodbye.
Thank you.
Bye-bye. Bye-bye.